Okay, Chris, you can share your screen.
Alrighty. Yep. Can everyone see this?
Yes.
Alrighty. I'm Chris Capolini. I'm a vascular surgeon in New Jersey, and I'll be your host tonight. We have two articles to discuss: 10-year experience using cryopreserved arterial allografts for vascular reconstruction during major oncologic surgery, as well as a report of the safety of prophylactic spinal fluid drainage in open and endovascular thoracic and thoracoabdominal aortic aneurysm patients. Thank you to our presenters today, out of LSU, Dr. Sheehan and Dr. Love, and out of the University of Tennessee, Dr. McNally and Dr. Lambert. Also, thank you to our special guests, Dr. Matthew Eagleton, the immediate past president of the SVS, as well as Dr. Sridharan. As a general reminder for tonight, please stay muted. Please submit your questions or comments in the chat. The moderator may call on you to ask your question. As always, the event is being recorded for on-demand access. And please join us for the next SVS Online Journal Club on Wednesday, December 10th at 6 p.m. Central Time. That'll be hosted by University of Washington. And sign up for 2026 is open. Please use the link in the chat to secure your spot to host and present. With that, let's move on to the first article.
That's me. Thank you. So our article deals with cryopreserved allograft for reconstruction after oncologic resections. Every time I go to a general surgery conference, seems like they're talking about different types of drains or feeding tubes, and this has been going on since I was a resident. But then when you want to make fun of them, I realize we've been discussing conduit as vascular surgeons since the dawn of time. And aside from certain circumstances like lower extremity bypass, I've never been convinced that it makes a huge difference what type of conduit we're doing, other than in special circumstances. When we do oncologic resection, general rule of thumb that I think everybody agrees on is for IVC, iliac veins. Ring PTFE is probably the best conduit, with or without a fistula creation. And then for arterial reconstructions in the abdomen, most people would use femoral or saphenous vein. There are groups who use SFA, refitted SFA for conduit. And then obviously some people use synthetic or bovine. Special considerations are when you're doing oncologic resections and there's a vessel involved, all comers have about a 50% 2-year survival. So I'm not completely convinced that patency is really the main outcome we should be worried about here with only a 50% 2-year survival. But risk of infection is high with a lot of these. There are a lot of them are clean, contaminated cases because of resections of the bowel or biliary tree. And then also, obviously, resections of the pancreas have a high risk of leak and infection or kind of erosion into the graft with pseudoaneurysm formation. So with that said, we're going to have Dr. Love go through this paper.
Okay. Alrighty, my name is Dr. Love. I'm one of Dr. Shane's residents, and I'll be presenting 10-year experience using cryopreserved arterial allografts for vascular reconstruction during major oncologic surgery. Article characteristics. This was published in the JVS March 15th, 2025, and the institution was the Division of Vascular and Endovascular Surgery at Mayo Clinic in Rochester, Minnesota. This was a single center retrospective cohort study. The goal of the study was to investigate the use of femoral and aortoiliac cryopreserved arterial allografts as a conduit for vascular reconstruction in the resection of abdominopelvic, peripheral, and head and neck tumor resection cases. So the methods, they looked at consecutive patients with or without suitable autogenous conduit undergoing in-block resection of vessel-invading tumors and vascular reconstruction using cryopreserved arterial allografts. This was from 2010 to 2024, and all patients were over the age of 18. The conduit of choice and decision for resection was at the discretion of vascular surgeons and surgical oncologists at the time of the case. All cases had been deemed to obtain R0 resection, and there were no cases that were greater than that. Primary outcomes measured were patency and freedom from cryopreserved arterial allograft related reintervention. Secondary outcomes were allograft related complications. This is getting, is there a way to move you guys so I can see the whole screen?
You could minimize the.
You can move people around as much as you want.
Okay, so I can like minimize this and that doesn't affect y'all?
No,
Okay, thank you so much. So as I was saying, primary outcomes measured were patency and freedom from allograft-related reintervention. This paper defined patency as primary patency was maintained without secondary intervention. Primary assisted was maintained with secondary intervention, but without occlusion. And then secondary patency was restored with secondary intervention after an occlusion had already been noted. As I said, it was from 2010 to 2024, and all patients were older than 18. Secondary outcomes were cryograph-related complications, freedom from tumor recurrence, and overall survival. And then the statistical analyses used were Kaplan-Meier analyses that were censored at 24 months, and these were compared using log-rank test. Okay, so when we're looking at the results, this is so out of order. Here we go. So first, looking at patient peri-procedural and post-operative characteristics, there were 44 patients and 44 vascular reconstructions. The majority of tumors resected were intra-abdominal, and the most common tumor type was a pancreatic ductal adenocarcinoma. There was a heterogeneous mix, though, of the anatomic locations and histopathological types. As I said, the majority were intra-abdominal, but there were other cases. The allografts were used in 43 of the 44 cases at the index tumor resection. There was one case, however, that required early post-resection or required a graft placed at early resection, 7 days for acute mesenteric ischemia following resection for esophageal carcinoma. However, in all the 43 cases that underwent vascular reconstruction at the time of index tumor resection, all of these were placed in an interposition bypass or interposition graft. The only one that underwent bypass was the one early post-resection complication. In total, there were 93 conduit cryolife vessels utilized. 61% of these were femoral and 39% were aortoiliac. 32 patients required multi-vessel reconstructions. And as I previously mentioned, of the 43 interposition grafts performed, 14 of these were branched. The most common arterial reconstructions were the common hepatic, celiac, superior mesenteric artery, and the most common veins were the external iliac, the common iliac, and the portal vein, but other locations were intervened on as well. And so then looking at our primary outcomes, here was the first figure in the article showing that there was no difference in primary patency, primary assisted patency, or secondary patency for arterial versus venous reconstruction. And then here we see that both arterial and venous reconstructions had a freedom from cryopreserved arterial allograft related reintervention at 24 months. Then going forward and looking at secondary outcomes, as I previously mentioned, these were graft infection, structural components, stenoses, overall survival, mortality. Stenosis was observed in 25 patients at the anastomosis and 18 and within the graft for 7. Of these, only 10 progressed to graft occlusion, while 5 experienced occlusion without a prior stenosis. And surgical intervention was only required in 10 additional patients. The most commonly occluded graft was the common hepatic artery. And then the most important takeaway, I think, from this table was something Dr. Shahan already mentioned, but structural defects in the development of pseudoaneurysm. So all of the structural defects were in cases that underwent pancreatic ductal adenocarcinoma resection. And the paper is presuming that these structural defects were secondary to, like he mentioned, bile leaks and just the hostile environment that that creates. And then this was in the supplemental data for the figure, but I found this particularly interesting because they noted that survival appears to be similar for all tumor types, so non-pancreatic versus pancreatic. But then when you look around 30 months, pancreatic starts to differ from non-pancreatic tumors, suggesting that that's something's happening at that time frame. And then at 36 months, pancreatic tumors have an overall survival of 23%, whereas non-pancreatic have a higher survival of 50%. So discussion for this paper was, it builds on a lot of like prior data that we already know in regards to tumor resection and oncologic surgery, but there's not much in the research specifically looking at conduits when undergoing these interventions. And so this paper mentioned quite a few other reports in the literature that discussed either vein or prosthetic conduit when undergoing major oncologic surgery. This first one, Carpenter et al., did a 12-month study looking at the primary patency rate for patients undergoing arterial reconstruction in major oncologic surgery, but most of the tumors were thoracic, but they used prosthetic grafts, and they found that they maintained a 12-month patency greater than 80%. Another study looked at 24-month overall patency rate, and they found that when using venous reconstruction or venous conduits or PTFE, they also reported infection rates around like 11. And then the rest of the papers were looking mostly at like specifically for like oncologic vascular surgery. They didn't define what that specifically means, but they basically were getting at that there's limited data on this issue, and there's not a lot known about which conduit is best for these intra-abdominal tumors. So in conclusion, cryopreserved arterial allografts offer anatomical compliance and resistance to infection for oncologic reconstructions. They have acceptable patency rates and freedom from intervention. However, in this study, this was not compared to autogenous or vein conduit or prosthetic. And then this paid special attention to pancreatic tumors, as the majority of patients with pancreatic tumors were the patients in this case. And they highlighted that special attention should be served to these patients when considering the conduit, as there's specific challenges with this case.
Okay, great. Are you finished, Dr. Love, with your
Yes.
presentation? Okay, perfect. Thank you to the LSU team, Dr. Love and Dr. Shahan, for presenting this paper. I see some comments coming up in the chat, which I'll try to read and ask. But before we get to that, did the authors go in a little bit to their medical management of these patients and their follow-up protocols in the paper?
Yes, ma'am. What specific medical management are you talking about, like pre-op, like neoadjuvant therapy or afterwards anticoagulation?
Yeah, afterwards, did they maintain patients on anticoagulation, antiplatelets, duration, and what was their surveillance protocol for these?
Yes, ma'am. So they said all patients were seen in clinic. They had like a 3-month or 1 month, 3 month, and then yearly basis. Most patients got CTs during admission, and then they repeated them on a monthly basis for the first year, and then tailored that on an individual basis after the first year. But they also mentioned that other imaging modalities were used, such as ultrasound, MRA, and traditional angiography. And then from a standpoint of anticoagulation, they said it was largely individualized. The majority of the patients were discharged on aspirin and anticoagulation. There were some patients that were not discharged on both and either one or the other due to being deemed as a high bleeding risk. But they did not go into that further in the paper or in the supplemental data.
Okay. So we have a question. I think Dr. Hingarani in the chat noted that surgical oncologists are sometimes resecting multiple mesenteric arteries and veins, adding to the complexity. From the paper, I think it was the majority of cases had more than one vessel reconstructed. Is that correct?
Yes, ma'am.
And did the authors note, were there any increased rates of complications in patients with multiple vessel reconstructions?
No, ma'am.
Okay. And the next question in the chat was just relating to, it seems like, at least in this case, there seems to be a lot of preoperative evaluation. These are being done with discussion between the vascular surgeons and the surgical oncologists, it sounds like, rather than being called in emergently, which is probably ideal. Then a note about HLA matching for cryo with improved outcomes. Was there any discussion of that in the paper or the supplementary data? I know this is not your paper.
No, in the discussion, they mentioned one of the papers that had an extremely high, like greater than 95% patency rate, and an extremely low infection rate used exactly what you were talking about, the HLA matched donor cryopreserved graft. But this paper did not use those, and they did not talk about why or kind of alternatives or like comparing them.
And the next question just gets to sort of cost effectiveness. I don't know if you have any thoughts on cost effectiveness. Dr. Sheehan, when he was bringing up this topic, kind of talked about, this life expectancy is not particularly long in these patients. So long-term patency maybe isn't the most important thing. Any thoughts? The authors note that their primary conduit of choice is the patient's SFA, other than when the SFA is occluded or in the cancer territory. Why use cryo over patients' autologous conduit like SFA from a cost effectiveness standpoint? Any thoughts to that?
I think I'll bail her out a little bit. She's a PGY too and didn't write this paper. But I think we can all kind of think about this. I don't know. The cryo, I know the lower extremity ones are about 10 grand, is that right? And so these are probably more than that. We don't use a lot of cryo, so I don't know what they cost. But yeah, I mean, and there's a cost to kind of taking someone's SFA out, right? And throwing some Dacron down there as well, or bypassing with a vein or whatever people are doing who are doing that. Not a financial cost, but obviously a cost to the patient. But I think this really, I mean, to me, this really plays into the survival of these patients. And it's almost like doing bypasses. Well, in the old days, I think dialysis patients live a lot longer now. But when we were first reporting on bypasses in dialysis patients or even carotid surgery, they weren't living long enough to kind of get a lot of benefit out of it, and certainly weren't living long enough to get benefit out of vein versus PTFE for some of the bypasses. So I think here we have a similar situation where if there's vessel involvement in an intra-abdominal tumor, you can't say that their survival is great. And so I think that definitely plays in. And I think somebody, I'm sorry, I can't read the comments right now, said something about the patency in the veins was similar to the arteries, right? And similar, and I think that kind of may be skewed by the survival we're looking at here. When we were comparing PTFE to vein in the classic papers in lower extremity, we're looking at 5-year outcomes, right? At least. And now we're looking at, I think the skew of these survival curves goes above 10% pretty quickly because the survival of the patient is so low. So I think that kind of speaks to, maybe not use the most expensive conduit that you can find.
Now, I was gonna, do you do a lot of these types of cases, or Matt? I mean, we do quite a few of them, and I do like cryo, but for some, I use it mostly for bigger conduits like aorta or iliacs, not necessarily for some of the smaller vessels like the celiacs and different thing that they used here. I would be concerned that those would narrow.
Yeah, I agree. We don't use cryo at all, really. And so I now why so for aorta, why is that your preference? Is that
They're always taking out a kidney or some bowel or something, and so I'm always worried that it's going to get
infection?
infected.
Okay.
That's tends to be there it seems to be always like some kidney or a piece of bowel or something coming out. Matt, what do you guys do at MGH?
We don't use a lot of cryo either. I think we use predominantly prosthetic or harvesting a vein conduit from somewhere. We're pretty aggressive with femoral vein, not saphenous, but femoral vein. We have a few that are prefer to using actually jugular vein, which works as a nice conduit for some of these locations. If you have to know about it ahead of time, they haven't stuck a big line in it. I think we've shied away from cryo stuff. One is the cost, and I think it's a bit of a fallacy to say you use cryovein and it doesn't get infected, because I've dealt with enough cryovein infections that I know that they can get infected. Just because you're using it doesn't spare you that torture when they come back in infected.
Yeah, I know Dr. Lyons mentioned that that you guys use a lot of femoral vein. I would think femoral vein would be a better conduit than SFA even, just because of the compliance of that potentially in those areas.
It depends. I mean, here we go talking about conduits the whole time. Well, I guess that's what the paper's on. So then we can talk about NG tubes and feeding tubes and dub off tubes like they do with Gensur. But I mean, the thing about the femoral vein, right, is sometimes it's just too big, to use, when you're reconstructing like an SMA, and that some people have just giant femoral veins, and you get this kind of like balloon shaped conduit, which is always a little bit distressing. But yeah, I think it's yeah, when the size is not a mismatch, I think it's a great conduit. Probably underused.
I don't have any experience, although I've heard it used as taking a bovine pericardial patch and sewing that and creating your own tube out of that. But anybody have any experience with using that as a conduit in these situations? I do not.
Sharif Alozi was here, and he talked about it. He takes a piece of it and uses a stapler, a vascular stapler, and creates the tube that way. When he was presenting a year or so ago on another paper, he mentioned that, or he talked about that. I thought that was interesting. I've not done it yet, but I have sort of thought about it a couple of times.
Yeah, you would think if you could use that, then why not, bovine carotid, because we do tend to use some of that for infected fields, and like Dr. Gilton said, it's certainly nothing is immune to infection. And if you especially if you have gram negatives around, anything can get infected, even native. So
What's interesting, you say you don't have cryo. We don't have we don't have artegraft, or we don't have bovine carotid. So that's something we haven't gone to.
yeah, I don't know. Yeah, somebody put artegraft is the one we have here, and it's I never saw it in my training, but maybe it's a southern thing. I don't know, but they certainly have a lot of it here on the shelf, and it handles well. I think it tends to stricture at the anastomoses. I've noticed you really have to bevel those when you use it, but it's certainly more resistant to infection than PTFE is. But yeah, and like Dr. Lyons said, like the classic literature on bovine stuff is it does kind of degenerate and form pseudoaneurysms later on. But again, what it depends upon what, your life expectancy here is, and what exactly, it's all happening.
We have a young, oh, go ahead, Matt, sorry.
Back of that, Amal, I think if, at least when I was thinking about cancer surgery and Whipple's especially, my teaching from 100 years ago was if you were that so much involving the blood vessels, they weren't going to live very long.
Right.
I don't know if that thought process has changed much, frankly. I opt to take some of the other modules when I renew my general surgery boards, so I haven't really kept up with that data.
Well, they're certainly
But
more aggressive here, I'll tell you, than we ever were. And I don't know if it's really kind of substantiated, but yeah, it was the same thing. You would never kind of carve tumor off the portal vein, right? And not, certainly you wouldn't take the SMA and celiac out or anything like that. But now there's, some literature on it, I guess. And you could see Mayo Clinic clearly they're doing a lot of it. So
So do the authors kind of allude to in their conclusion where this fits in their algorithm at this point? Dr. Love, has this sort of become with their results? Is this something that's first line, or do they reserve it only for patients without alternative options?
No, it seems like they're still using like what someone mentioned earlier, like SFA as a first option, and then using like autogenous, like from the patient graft, when possible, but then they'll use this over prosthetic, it appears.
Okay, great. Thank you so much, and thanks for the discussion. I think we're going to move on to the next paper at this point, so I'll mute myself.
Yeah, excellent discussion. Let's move on to the University of Tennessee presenting.
All right, good evening. Can everybody see our screen? Okay.
Yes.
Great. I want to thank the program and Misty Humphreys and the Journal Club for allowing us to present this year. We've really enjoyed this each year when we have an opportunity. So tonight we have the pleasure of discussing and reviewing the paper at the University of Wisconsin titled "A Report of the Safety of Prophylactic Spinal Fluid Drainage in Open and Endovascular Thoracic and Thoracoabdominal Aortic Aneurysm Patients." This paper is from Dr. Skoda, with senior author Dr. Wen, again at the University of Wisconsin, powerhouse group and really reporting performing these large open and endovascular thoracoabdominal aortic surgeries. I'll be presenting tonight with our fantastic first-year fellow, Dr. Aaron Lambert. You can see my screen is not titled appropriately. I snuck up to the fellows room tonight. As I've seen through this forum, too many complications and transitions of slides, so I figured I'd just come up here and make this easier. So we just put all our slides together. So a couple intro comments, and then I'll let Dr. Lambert really dive into the paper here. As far as our topic, we're talking about spinal cord ischemia in these thoracic and thoracoabdominal aortic aneurysm repairs. This is really a devastating complication. I've listed some reported spinal cord ischemia rates. These are permanent SCI rates in both open and endovascular repairs. I divided it by Crawford extent. Not surprisingly, types 1 through 3 in a lot of these papers are grouped together due to the extent of coverage or treatment versus type 4, which usually have lower rates. But really, what's the impact here? Sal Scally down at the University of Florida and their group reported on this impact way back in 2013, talking about the significance here with decreased long-term survival on those patients with these complex thoracic endovascular repairs. Those experiencing spinal cord ischemia had a 37-month survival compared to those without it at really only 71.6 month. As far as prevention and treatment for SCI, the overall goal here really is you want to optimize your hemodynamics and oxygen delivery, initiate hypothermia during the surgery, administer neuroprotective medications, all with the goal to reduce direct neuronal and reperfusion injury. Most centers performing these types of surgeries, both open and endovascular, have a prophylactic treatment bundle, which includes, and it really is described in their paper as well for their bundle, permissive hypertension, steroid administration with methylprednisolone, permissive hypothermia, naloxone drips, mannitol, having an elevated hemoglobin greater than 9, and then the use of spinal fluid drains. And the whole goal, or for the trainees, or why do we put in a spinal fluid drain to begin with, is the whole goal is to increase your spinal perfusion pressure. And how does that work? Well, the spinal cord perfusion pressure is really related to your MAP minus your spinal fluid pressure. So you want to increase your MAP and drive down with the drainage your spinal fluid pressure to elevate that perfusion pressure. As far as spinal fluid drain complications, this paper out of the group at the University of Colorado in 2022 published their review at their center of mild, moderate, and severe complications, compared it to the literature as well. And I won't read you the rates of each of these, but you can see some of the mild complications really are just dislodged or occluded catheters or CSF leakage, but didn't require any intervention, to moderate complications, which can be spinal headaches or CSF leakage requiring blood patches. And finally, the severe or dreaded complications is an epidural hematoma, intracranial hemorrhage, or even worse, herniation. So you can see I wanted to present a couple of papers here in contrast to the Wisconsin paper here. So I have two more. I just wanted to show you this paper recently published in 2020 by Dr. Oderich when he was at Mayo with their complex endovascular aortic aneurysm repair and use of spinal drains and their complications, which were significant. You can see in their 187 patient cohort, they had 10% drain-related complications, with severe complications being up at 5%. And then most recently is this meta-analysis and systematic review published in JVS in 2024. It was only 6 studies. So they were all retrospective and single center studies, but it was over 1,000 patients with 730 spinal fluid drains. I'm not going to read you all the details here, but you can see significant related drain mortality listed at 1.4%, a high overall morbidity, a little over 25%, and the severe complication rates listed here. And notably, their conclusions really said that there was a significant incidence of CSF-related death and substantial morbidity. And the last line here was really their call for careful consideration regarding the routine use of prophylactic drainage due to the accumulating evidence of risks associated with spinal drains without proven benefit in this specific context. So setting the stage, we've really been following this literature over the last several years for these type of repairs at our center. And then the University of Wisconsin has come out with this paper showing their outstanding results. So I'm looking forward to the discussion and appreciate, again, the opportunity for us to present today. With that, I'll leave Dr. Lambert for a deeper dive here.
So thank you, Dr. McNally. So as Dr. McNally mentioned, our papers report on the safety of prophylactic spinal fluid drainage in open endovascular thoracic and thoracoabdominal aneurysm patients. Again, this is from Dr. Skoda and the group predominantly at Madison, Wisconsin. The characteristics of this is sourced from the Journal of Vascular Surgery. Its initial electronic publication date was June of this year. It's presented in this month's issue in November 2025. The institution, again, University of Wisconsin, predominantly also one affiliation with the University of Chicago. And the design of this is a retrospective single center observational study. The aim of this article was, as kind of alluded to, there's varying numbers in the literature, but the overall risk of spinal fluid drainage is much debated, and its benefit in terms of preventing spinal cord ischemia is up in the air. So this was kind of assessing the risk of prophylactic spinal fluid drainage in patients undergoing these complex open endovascular thoracic and thoracoabdominal aneurysm repairs, and kind of better assessing the risk of performing prophylactic drainage. And again, I'm not going to belabor this point because Dr. McNally laid an excellent intro to this article, but again, spinal cord ischemia is a devastating potential complication of these procedures, and spinal fluid drainage is very frequently included as one of the kind of bundle of interventions to mitigate this risk, but has its own inherent risk of the procedure, including kind of the most severe complications of epidural hematoma, intracranial bleeding, spinal headaches, and infection. And this article assesses, a huge cohort of patients. There's over 1,445 patients in it. I think over 1,000 spinal fluid drainage catheters placed during the course of the study period, and gives a better assessment of kind of the results you can achieve with a lot of expertise and experience in placing them. So this study, again, as I mentioned, was a retrospective study. It utilized an institutional prospectively maintained database. It's spanning the period of 1987 to 2023, so quite a long period. During the entire course of this, intraoperative and postoperative spinal fluid drainage was part of the protocol for preventing spinal cord ischemia throughout, as were the other components. Again, kind of, I think, common ones that appear in the literature, but permissive hypothermia, methylprednisolone, 30 milligrams per kilogram up to the 2 gram mark, naloxone, mannitol, aggressive management of oxygen carrying capacity with the hemoglobin transfusion target greater than 10, and also maintaining spinal perfusion pressures of over 60 to 70 millimeters of mercury. Open procedures that clamped on the proximal arch also utilized early in the study period thiopentol, later in the study period phenobarbital for burst suppression during the course of proximal clamping. Other components of their kind of methods and bundles for spinal cord ischemia prevention. Heparinization was not used if there were no cardiac valves, prior grafts, and they were clamping distal to the left subclavian artery. 3,000 units of heparin was given, and an ACT goal of 225 to 250 was maintained if there were the cardiac valves present, prior vascular grafts, or if the clamp was placed proximal to the subclavian artery. And again, deep hypothermic arrest was used during proximal arch repairs. In terms of the spinal fluid drainage protocol itself, all these drains were placed in all patients undergoing Crawford type 1, 2, and 3 repairs, as well as type 4 repairs that involve visceral patches. Endovascular repairs covering greater than 12 centimeters of the thoracic or thoracoabdominal aorta also received spinal fluid drainage. There was strict coagulation criteria maintained both pre, intra, and post-operatively, where they had platelet counts of at least 100,000 platelets per microliter, an INR less than 1.3, and fibrinogen levels over 200. They had a dedicated group of cardiac anesthesiologists who placed, maintained, and managed all complications of the drains throughout the duration of the mean in the patient. And then from the early study period from 1987, the first 13 years to 2000, they were placed by anatomic landmarks. More recently, from 2001 on, they've been placed with fluoroscopic guidance. These were all placed in the OR prior to the case beginning. Just a few more characteristics of this. The drainage goals for higher risk Crawford 1 through 3 repairs, they drained to spinal fluid pressures of less than 5 millimeters of mercury. For Crawford 4 repairs, these were a little bit more higher spinal fluid pressures were tolerated to less than 8 millimeters of mercury. The drains, again, were maintained intraoperatively and postoperatively until 48 hours routinely if you had baseline lower extremity motor function. MAP in drainage was titrated to achieve spinal cord perfusion pressures. There's not mention of elevated MAP goals per se, but kind of more goals driven at spinal cord perfusion pressures of 60 to 70 millimeters of mercury. Blood in the drainage at placement did not postpone surgery. However, if blood appeared later in the course, drainage was stopped and appropriate imaging was obtained, generally with the CT of the head. And headaches were routinely treated, or post-spinal drainage headaches, when they were removed, were routinely treated with blood patches. So some of the results from this paper, I think the first thing to highlight here is just, again, the kind of remarkable volume of cases. Here, there were 1,445 total repairs. 71 or over 71% of these were performed in an open fashion. Just under 30% of these were performed in an endovascular fashion. The first table here, I apologize, they're kind of cluttered tables, but the first one highlights the different Crawford anatomy that they treated during the course of these studies. And you can see they're fairly well distributed between types 1 and 4, and kind of each one representing roughly a fifth of the cases that they were operating on. The endovascular approach obviously becomes more prominent in the thoracoabdominal. Type 1, 2, and 3, and type 4, including the visceral segments, are obviously less prone to or less acceptable for endo approaches. So those were lower numbers there. Spinal fluid drainage, again, was, I think, routinely employed in 2/3 of the cases, as you see from the overall numbers. I think from a patient characteristic standpoint, the only cohort of patients who routinely did not receive spinal fluid drains were the traumatic cohort, where they had, I think, 78% of them did not receive spinal fluid drainage. Otherwise, everybody else generally received a spinal fluid drain. I think throughout the entire course of their study, they only had 6 spinal fluid rescue drains placed postoperatively for postoperative ischemia symptoms. Remarkably, from placement, major complications were incredibly low. There were 6 total this entire period. So there were 5 in open cases. There were 3 subdural hematomas that resulted in hemiparesis. There's 1 cerebellar intraparenchymal hemorrhage that happened after an intraoperative hypertensive crisis that required decompressive craniotomy. They had one delayed epidural hematoma after resumption of anticoagulation for mechanical prosthesis in the heart. There's one major complication in the vascular case where, again, they had an intraoperative hypertensive issue that resulted in a cerebellar intraparenchymal hemorrhage. The mortality when the major complications did occur was quite high. 4 of the 6 patients did ultimately die from these. But again, you can see the neurologic complication rate in this for all drains placed prior to 2000s. This was done by Anatomic Landmarks, was 0.3%, and all the drains placed under fluoroscopic guidance again was like 0.67%. So like fractions of other described rates in the literature. Secondary complication rates again are there. So roughly 20% of patients had blood in the spinal fluid drainage at some point. On the further work of this, 9.9% of patients in the open cohort and 6.1% in the endovascular cohort had intracranial blood that did not result in any neurologic sequelae, so kind of asymptomatic intracranial blood. And overall, just under 9% of patients required blood patches. So there were bleeding complications, but generally clinically irrelevant for the most part. And then again, from a prevention of the kind of complication they're aimed at, spinal cord ischemia rates throughout this were also, I think, very excellent. 41 of 733, or just over 5.5% of the open patients had at least transient spinal cord ischemia symptoms. 31 of those were permanent, so just over 4% rate of permanent spinal cord ischemia in the open patients. Endovascular had 5 permanent spinal cord ischemia patients, so just barely over 1%. None of these were radiographically, as far as I could tell, related to the spinal fluid drainage system. None of them had spinal hematomas on MRI after further workup. But again, kind of remarkably low rates of major complications from the placement of the drains, and also excellent results in terms of preventing spinal cord ischemia. From discussion of these results, so again, as we alluded to earlier, previous series of single institution studies have described rates of epidural hematoma, neurologic deficits, infection, major complications related to the spinal fluid drainage system, much higher than this, nearing 5%. In this large single institution high volume study, they had rates of 0.7% in open cases and 0.4% endovascular cases. And as part of a bundle aimed to mitigate the risk of spinal cord ischemia, also had rates of spinal cord ischemia in both their open and endovascular patients that were, I think, at the some of the best rates you'll see in any of the literature as well. So I think from a risk benefit standpoint, they continue to find that this is beneficial in terms of having below reported rates of spinal cord ischemia as well, and they're safely able to do it. Other things that are highlighted in there is, again, these are not without some complications. There's obviously blood in their spinal fluid drainage. There's blood in the head on several of the CT scans for patients who have that. They do highlight that they have a very strict, protocolized approach. Anytime those shows up, they have a dedicated group of cardiac anesthesiologists to assess and maintain the drains and manage them throughout their duration, the patients, and have kind of on-hand expertise at all hours to intervene on any issues as they crop up. I think overall, again, highlighting spinal cord ischemia is devastating. Avoiding that is, paramount in these surgeries, and that if you know your institutional capabilities to place the drains and have an idea of the actual risk inherent to your institution, that they are a valuable part of mitigating the risk of spinal cord ischemia. They also highlight that, several of the papers or protocols advocating not routinely performing spinal fluid drainage, you'll have rescue drain placements, and rescue drains have been studied and kind of throughout the literature have higher complications anywhere than plans, controlled drain placement prior to cases. I think the biggest limitations of the study is, cited, they do have, a large center. They're doing a large volume of these cases that I think are probably hard to hit the numbers for most other institutions. And they also have a dedicated group of anesthesiologists and kind of care team that are experienced with the drains and know how to manage them very well and have a well-established protocol that's followed. And, again, while the spinal cord ischemia prevention rates are excellent in this, this is all part of kind of a bundle, and it doesn't necessarily isolate out how beneficial the spinal cord fluid or spinal fluid drainage system is in isolation. So while you have a very low risk of major complications in this paper, you still don't fully know how, effective the spinal fluid drainage system is in the context of that bundle of preventing spinal cord ischemia. And I think overall their conclusion, again, was routine spinal fluid drainage can be performed safely and can contribute to having excellent results in terms of protection from spinal cord ischemia at high volume centers, and should be considered for routine practice and protection as long as you have the institutional capabilities to place these safely. Thank you.
Thank you very much, Dr. Lambert and Dr. McNally, for presenting this. A ton to unpack here, and we could probably talk about this, or I could talk about this for hours, because I kind of live this every day. There have been a couple of papers recently. You highlighted some of them with Dr. Oderich, and there's also one out of the Cleveland Clinic with Sean Leiden that sort of summarized their experience there, where we see there can be some significantly elevated complication rates associated with it. And this is a beacon of hope for those of us that use spinal drains, is that with a dedicated approach to doing this and long history of doing this, you can significantly improve your outcomes. I think a lot of this effort out of Wisconsin is due to Charlie Akers' attention to this detail with regard to preventing spinal ischemia. And that group should be applauded for their approach to this. Not only are the complication rates low for the prophylactic measures, but their complication rates, including spinal ischemia, are pretty darn low. My question for you, Dr. Lambert, now with all this information out there, what are you going to do when you go into practice to prevent spinal ischemia in your patients?
I think kind of the most important part of this is, again, balancing your institutional risk. There are large data sets, so you can see different numbers there. And I think you have to be realistic about the institutional support you have and the expertise you have within the institution, because I think that can dramatically change what that risk benefit ratio is of using it. I think if you're at a place like Wisconsin where you can routinely place and manage those drains as remarkably effective as this group can, I think that absolutely I would routinely place the drain. I think the vast majority of people probably are not at an institution that has a case series of nearly 1,500 thoraco and thoracoabdominal aneurysm repairs, and I think you have to be more objective in assessing your capabilities to place those drains safely. And I think obviously that risk of major complication, if your epidural hematoma rate is going to be like some of the papers earlier where it's in the 3% risk, is that going to be worthwhile to do? And I probably suggest not.
Yeah. If we went back 10 years ago, and I can just speak from the US Aortic Research Consortium standpoint, we are probably draining everybody at the sites that are involved in that program. And even just recently, this past week, we've had an argument among our group about who even continues to place spinal drains prophylactically at all in their patients because of the concern with the complication rate and the number of adjunct procedures or utilities we can use to lower spinal cord ischemia rates independent of spinal drainage. Having said that, I'm a user of spinal cord drainage still. A lot of it's for what you already said. So if I have a high risk patient, which means they have some risk factors that may make them high risk for developing spinal ischemia, or it's an extensive length aneurysm I'm going to treat, I still use prophylactic placement of the drain. Why? Because I can't reliably get someone skilled at putting in a drain at 2 o'clock in the morning or 3 o'clock in the morning, and that seems to be when my spinal cord ischemia kicks in my patients. And there's nothing worse than having that happen at 2 o'clock in the morning and then trying to find somebody that can stick a spinal drain in them for us. So I think, and obviously I think this because it's what we do in our practice, I think that's a real indication for potentially placing a spinal drain. One of the changes we have taken, though, is not to necessarily drain the spinal drain if we're using it in that fashion, that we might just leave it in, and if they develop any symptoms, just open up the drain and let it drain. I think one of the potential benefits that we're seeing in the group from Wisconsin is the controlled placement of the drain. They do them all under fluoroscopic guidance. Our anesthesia group from Mass General went out and worked with them for about a week to understand how they approached it. They're also careful about when they place that needle to not let the fluid drain all over the bed for several hundred cc's just before you start the case. I think that's an important technical approach to placing spinal drains that we have to pay attention to. That's probably not well recorded when that happens, but you take that patient, you've drained a bunch of stuff, more than enough spinal fluid for probably the next 4 or 5 days, and then you're anticoagulating them and putting them under a large operation following that. So I think that may be one of the steps that we don't pay careful attention to that may be contributing to development, at least of intracranial bleeding complications related to the spinal drains. I'm going to open this up to some of the group. Mal, what do you guys do? Or Babakabai, what do you all do at your program?
I was just writing about it. So essentially, for the endovascular procedures, we rarely put prophylactic spinal drains. We do them if we get any spinal ischemia, we do it afterwards. We also try to not cover the entire aorta in one setting if we can. We stage the procedures. We find that the incidence of spinal cord ischemia goes down if you can stage the procedure in any way. For our open thoracoabdominals, we do tend to put the drains in prophylactically. Although lately we have also been doing a series of sort of especially with the type 2s, trying not to repair the entire aorta open at the same time, trying to maybe do the top endovascular and then come back in 6 weeks and do the rest to try to prevent spinal cord ischemia. But with the open procedures, we tend to put them in.
Great, thank you. Mal?
Yeah, we used to do these at the university hospital and put them all in, and we're all friends here, so I can divulge. We had a lot of complications, and it was mostly ICU and nursing and just kind of miscommunication, and it was incredibly frustrating for me. I think I talked to you, Matt. I know I talked to Andy a bunch, and just trying to get it going, but we just had inconsistent care, and so we moved, kind of the open aortic program anyway to a different hospital in our system, where we do it now with our with a different group of anesthesiologists, of critical care folks, and so, but yeah, I believe that it's the way to go, Matt. But it's like such an institution dependent thing, right? You can do the best surgery in the world, but if the nurse puts the drain on the floor or something, then it's a very vexing problem to have.
I think that's actually something that we don't think about, as surgeons, and especially for young surgeons coming out that are trained in places where we can do these procedures, but it really is the support of the group around you. We also, as Dr. Abai mentioned, we tend, because we do a lot of long segments, but we've tried to space them out. We can't seem to get all the patients to go to one ICU that know how to use the nurses know how to use the drain. And it's really frustrating because you think this is a big operation. We're doing serious things. And sometimes I just feel as if others don't take it as seriously. And it's really a crazy phenomenon that we've seen. But I sort of agree with you, Matt. I don't want to be I'm not calling anybody at 2 a.m. to come put the drain in, because that's even worse to try to find somebody. So if we are doing even the second stage and it's a long part of the thoraco going into the abdominal, we may put a drain in just to be safe.
Yeah, I agree. That's how we approach it ourselves. Let me throw this out for conversation. I talked a little bit about large volume drainage inadvertently when the drain goes in, that I don't think we keep an eye on. There are a number of places that will drain to pressure. There are a number of places that'll drain to volume. There are a number of places that'll stop draining if you reach a certain volume. When I was at the Cleveland Clinic, the vascular surgery ICU, we would just leave them open and drain to pressure and just let it run continuously, independent of the volume. The cardiac surgery group in the ICU next to us, though, would not do that, and they would set a volume limit. How many of you are setting volume limits on this? Interestingly, when Sean wrote about the outcomes from that, we didn't see a difference in complication rates between the two sites. But I'd be interested in hear what Dr. Lambert, what your group does in Tennessee, or what any of the rest of you do with regard to volume management of CSF fluid drainage.
I think that's an interesting question. I trained with Adam Beck down in Florida over 10 years ago, and we drained with open drains, just like you stated. And when I came here with kind of re-education, I felt like we could control it better just by setting a set volume instead. So I changed and adapted based off our institution. But it was different than what I had trained before. But I've definitely seen it both ways. I know other people are going to answer this question, but I was going to ask you a question as well. If you have a bloody tap or slightly bloody tap before your case, do you cancel? This group does not. I was curious how you handled that. Also throwing.
I have to say I cancel. I don't believe anything or anybody. So if I see some blood there, that patient's about to screw me if I move forward. So
we do as well. I was surprised.
We've had a couple of intracranial hemorrhages, and we found a couple of patients, and I don't think this is rampant, but it's interesting to me because I hadn't thought about this ever in my life, that ended up having scurvy. And scurvy causes bleeding disorders, and they were people who had stopped eating fruits and vegetables, frankly, these older people, and they really had significant vitamin C deficiencies. We check all of our aneurysms now for vitamin C deficiency, and I'll put them on vitamin C ahead of time if they're low. I just tell them to eat a couple of oranges, maybe even we'd be better off, but it's happened enough that it worries us. So something new we can look for maybe to help prevent complications from spinal ischemia is the presence of scurvy. It's pretty easy to treat. Anybody else want to add anything to this? Great presentation. Again, great topic. Something I've been very interested in my career, and I'm not surprised by the excellent outcome in Dr. Akers' group. I just wish we could reproduce that everywhere else. I think one of the important things that's been mentioned in the comments, though, is just having a protocol that everybody sticks to and everybody follows, and to notify people early if they're starting to develop some signs or symptoms of spinal ischemia. So if you don't have a prophylactic training, we can get a rescue drain done in a relatively short period of time. I counted my 7 seconds, which I'm supposed to give everybody. So Dr. Cavallini, I'm going to turn it back over to you. I think there are no more questions.
Sure, unless there's any other questions or additional comments. Thank you everyone for the excellent discussions tonight. And stay tuned for the next series next month.
Thank you, everyone.
Thanks, everyone.
Thanks.